afternoon, everyone, and welcome to today's Department of Medicine Grand Rounds. It is my distinct honor to introduce our speaker today, Dr. Elias Zerhouni, one of the most influential figures in modern biomedical research, imaging, and translational science. Dr. Zerhouni is a professor emeritus of radiology and biomedical engineering at Johns Hopkins University, where he previously served as chair of the Russell H. Morgan Department of Radiology and Radiological Sciences, Vice Dean for Research, and Executive Vice Dean of the School of Medicine. From 2002 to 2008, he led the National Institute of Health as its director, overseeing 27 institutes and centers and more than 18,000 employees and a budget of nearly $30 billion. During his tenure, he introduced NIH Roadmap for Medical Research, launched the Pioneer and New Innovator Awards, and strengthened the national focus on translational science, health disparities, and open access to research. Following his NIH leadership, Dr. Zerhouni served as president of Global Research and Development at Sanofi, guiding international biomedical innovation from 2011 to 2018. He currently serves as vice chairman and president of OPCO Health and continues to advise numerous scientific organizations, including Lasker Foundation, Research America, and Foundation for the NIH. Dr. Zerhouni also has deep ties to our region and to our medical school, Eastern Virginia Medical School, where he served early in his career as vice chair of radiology and began forming many of the collaborative ideas that would later shape his approach to team science and translational research. He has often spoken fondly of his time in Norfolk and has continued to engage with EVMS through his support of biomedical integration initiatives and community partnerships. His contributions have been recognized worldwide. He is an elective member of both US National Academy of Medicine and National Academy of Engineering, as well as French Academy of Science. Today, Dr. Zerhouni will speak on evolution of research and healthcare from 1975 to 2025, offering a sweeping perspective on how biomedical research and US healthcare system have transformed over the past 5 decades and where the next frontier lies. We are lucky to have Dr. Zerhouni today. Please join me in warmly welcome Dr. Elias Zerhouni.
Well, thank you very much. Can you hear me okay? Just raise your thumbs up if you do. All right. Wonderful. And thank you for your kind introduction. I'm really pleased to speak to EVMS. I mean,
this guy's on, he's not even there.
Hello.
Elias Zerhouni is in wherever he's from at a desk.
Dr. Neighbor, we hear you.
Can you mute your microphone, please?
Are we okay? All right. Are we back on? Can you hear me okay? Okay.
Yes,
all right.
We can hear you. Yeah.
All right. Well, I see people showing up on the screen. That's why. Okay. Anyway, let me just go forward and tell you why I thought it was important to speak at the grand rounds. I was asked to do that and give you a perspective. I mean, I've been, I came to this country when I was 24, thinking that the best place to do my biomedical research was the US, and that the best healthcare system in the world was the US healthcare system. Fast forward, in my book, I recount my trajectory and my journey, and I wanted to share that with the readers because in 1975, I thought that we had the very best systems. Fast forward to 2025, I think we still have the best biomedical research system in the world, but I don't think we have the best healthcare system anymore. As you know, we are very costly, and we do not really achieve healthcare statistics that are competitive with those of other developed countries. So I will cover that for you. but I will also cover something that I think is important, and that is that what is the doctor of the future? What kind of doctor you want to be, and what do doctors need to be if they are going to be effective in the new healthcare system, both from the discovery endpoint to the delivery endpoint of healthcare. As you know, I've been a researcher, a physician scientist, and at Hopkins and then at EVMS and then NIH and various functions from academia to government to industry. So I have a perspective that might be a little good to hear and good to ask questions later on. But let me tell you what I'm going to tell you. First of all, I'm going to give you a concept of individual design, if you will, framework for you as an individual. The second, I will talk about the need today to truly be cross-disciplinary. You can't be a monodisciplinary person anymore, and I'll tell you why. I will talk about AI, because I think it's a revolutionary force that is going to affect us all. And then I'll talk about healthcare and its contradictions in our healthcare system today. So the first message I want to send you is that you have to have a self-image of exactly who do you want to be. And the best way I describe this in my book and my lectures is the letter T. So when you look at the letter T, there's a vertical and then a horizontal bar, right? Think of it as the vertical being your discipline, your skill set, what you know, what you're good at, what you're an expert at. You know, if you're a internal medicine, you want to know everything about internal medicine. You want to be deep. You don't want to be superficial there. So it's very key that you establish a base, a vertical base of excellence and in a skill that is hard to get, difficult to copy, you know, something pretty unique to you, whether it be in surgery or in medicine or social science, so, you know, mental health specialties, whatever it is, you have to be deep. But that is no longer enough. It was enough in 1975. When I came here, you could be just doing your specialty or whatever you were doing, then you would be successful. However, the systems we're in today, whether it be biological systems in research, as you look at the complexity of that, as we've discovered through the research that was done over the past 50 years, is very high. And you can't really understand that complexity without having connections to other fields around you. The same is true of the healthcare system. As you know, it's become very complex, very hard to navigate. So you can't anymore be an effective professional without having what I call the horizontal part of the T, which is the connectivity part. Now, why is that important? Because you're now codependent on others to be able to be effective in what you do. Why? Because of the complexity. You know, you need a radiologist, you need a pathologist, you need data from various sources, you need integration of that data, which means that you need to understand data sciences. You have the ability to analyze that, which means you may require AI now because the complexity of the data is such that you can't really tackle it from just one point of view. It's really hard, given the shortage of experts and doctors and nurses, to truly see that we will be able to serve the needs of the population, which is aging, requiring more care, and a workforce that is not growing at the same rate as the demand in a complex system. And so that's what I mean by saying, think of yourself as a balanced T, where your vertical is as large as your horizontal. You don't want to have a short vertical because that means you don't know much, but you talk about a lot of things. Or a very short horizontal, which means you would know a lot, but you don't connect. So that's a lesson I learned through my career where I had to connect to be effective. Now, why is it that you need to connect? Because one, the complexity of the issues you deal with require connectivity and knowledge, right? Second, if you truly look at how science has evolved, how medicine has evolved, it's a team sport. And there is a convergence across all fields within medicine. I mean, if you talk about any area of medicine, you come across immunology issues. Well, immunology goes across diseases. The same thing is true with physical sciences. It's really hard now to do medicine without understanding imaging technologies, pathology and pathology technologies, and the various biomarkers that are used and what they mean, and integrating all of that in a comprehensive understanding of the patient. So there's a convergence between medical, biomedical, physical sciences, and data sciences. And that converges in complex teams that are designed to address complexity. So whether it be surgical or medical, you really know that you can't be effective without a good coordination between complex teams, because medicine has become a team sport. It's no longer one provider dealing with one patient. And let me give you some data on that. When I was the executive vice dean at Johns Hopkins, we were facing a real difficult time in the 90s with managed care, and because our costs were going up across the board. And I said, why? Let's do some studies of that. So we did a study looking at the 1970s medical records at Hopkins, and then the 1990s medical records at Hopkins. And we asked the question, how many FTEs did you need to manage a single medical encounter? In the 1970s, there were 3 FTEs. There was one physician, one nurse, and one assistant. And that was it. I mean, you could do pretty much anything you needed to do with the FTE that gave you a little bit of biological data, maybe an X-ray, and then the nurse would take care of some of the measurements and steps you had to take, and that was it. Fast forward 1995, when I became the executive vice dean, we did that study. We look at our medical records. It took 19 FTEs to be able to take care of one encounter. Why? Because you had enormous growth in imaging, so you had to have that and the radiologist's time, a pathologist and the pathologist's time, and the pathology testing, and on and on. So it became obvious that you had a higher need for complex interactions to be able to take care of a patient, not even counting at the time the complexity of billing and being paid and following the new rules that were put together by Medicare without coming across fraud and abuse, and administrative complexity and regulatory complexity. So if you added all of that, you realize that as a medical system, as a physician, you were part of a more complex environment, which required you to be a balanced T person, not just a vertical I. So having said that, let me talk to you about what I think is a major driving force of change. That is AI. There's not a conversation that you have now at the level of discovery where AI now is used, for example, to deduct the structure of proteins because of the algorithms that have been developed called AlphaFold 3 or the RF diffusion algorithms, which predict from the sequence what the structure of the protein would be. That's a revolution. This was a 70-year-old problem that hadn't been solved before. The authors of that work received a Nobel Prize last year, and for good reason, because it completely changes the process of discovering and understanding complex biological systems. Now, at the leading edge of that AI research is essentially the ability to connect different proteins and understand how they interact, and then to design new drugs or antibodies or new biologics to interfere with that interaction, whether it be in health or disease. So that's one part of the spectrum. Fast forward, you also realize that you will need to have a better ability to select the patients that you want, for example, in the clinical trial. And to do that, you need to integrate very complex databases of patient data, plus biological data, plus the ability for you to test whether or not your biomarkers are responding to whatever you're doing. So any translational medical step will require also complex database analysis and insights. fast forward when you talk about delivery of medical care, I think today you're seeing already some what I call low-hanging fruit for the impact of AI. For example, decomplexifying the interaction with the patient. So it's what I call anti-drudgery, removing the drudgery that has been introduced in our environment as physicians in the interactions with patients, taking notes, making sure the codes are right, making sure the billing is correct, making sure, which meant that 40% of the time when you were talking to a patient, you were typing something. Today, you can do it without, moving away from the patient. You can have a conversation with the patient with the AI support in the background. I'm sure you've experienced that, and it does improve the quality of life of the physician, the quality of the interaction, the fidelity of the notes that you take, and then the completion of the notes very, very effectively. So that's one aspect of AI that I see already having made a difference. The other one is what I call interface technology impact of AI. What do I mean by that? Well, in other countries, innovation is not as regulated. And so what you see right now in China, for example, and even in Africa, the use of AI as a triage tool. It's done in the US as well. And I'll tell you where it's more applicable in our healthcare system. You see that the AI is sort of structured as an interface between the patient and the AI system. All right, the doctor is not in the middle there. So you see this in mental health already, and all of the data that we see right now indicate that patients actually sometimes do prefer a non-human interface because they can confide in the non-human interface with no fear of judgment, which is the case when you talk to a human. And so you can see an improvement there. Second, there is a company in China which is an insurance company. And obviously they wanted to do better for their patients and direct them properly. And so they created a chatbot. And the chatbot has become smarter and smarter over time. And they provide the consultation at 24/7. You can call that number. You can connect with the AI, and the AI will ask you questions. You can pose questions. Everything you say is transcribed, and the AI will start, filtering what are the issues you're dealing with. They also get data nationwide about current infectious disease status. Is there a lot of flu in an area? Is there a lot of COVID in an area, or whatever? And they come up with a recommendation, and the recommendation is either calls back, either you're okay, or we need you to see a physician, and they have 1,000 physicians available for consultation, which then leads to either a prescription, which they can deliver to the patient within an hour, or a referral to a specialist, which they can arrange directly. Very popular. They do hundreds of millions of consultations that way. Imagine if we could truly do this for our patients and be able to interact that way. But there is a next step to that, and that is what we call fleet management. Fleet management is a concept of managing a population of patients in a way that is interfacing between you, the healthcare system, the AI system, and the patient population, especially in groups where there is a commonality of approaches. High-risk diabetic patients, chronic diseases, heart failure. So you lump and you cluster your medical issues, not one patient at a time, but one population of patients at a time. And that is enabled by the AI system that sort of grows as a backbone of the interaction and the interface. So those are just a few of the things that you're seeing emerging. And the question is going to be, how deep is AI going to become part of us? Let me tell you, when I started my career, I really believed that computerized technology would be very important in medicine, especially in the medical imaging field. And I entered that field and I never looked back. It's been a lesson because it was at the intersection of physics and mathematics and data science and computing and biology. And I loved that because my fundamental training was in math and physics. And I'll recount that in my book if you're interested. But the key thing there was that this was a wave. There was a huge wave that was going to drive the world through computerization, the internet development, and so on. I had no idea how high that wave was going to be, but I could sense that it was going to be critical. And so I entered that field, and it reflects what I tell students. What makes you a good surfer is not the board that you have or the suit that you wear, it's really the wave you pick. And I think in this case, all of us here, whatever you do, research or development or any of those things, or just primary care or specialty care, you'll have to deal with AI. Just don't think you won't. And understanding it is not that straightforward. Understanding the applications will be straightforward. So when you hear that, let me give you a concept of at least my worldview of what's happening out there and how it's going to affect you. So right now, when you look at the news, you hear about all the tech companies, NVIDIA, Microsoft, and all that, investing billions of dollars in the field of AI. Why? Because at the core of the field of AI are going to be these data centers that can, store and manipulate billions and trillions of data points at a time, something we've never seen in the history of the world, and then do it in a way that generates insights that you can over time improve upon. So there's be a self-improvement thing, which is based on that fundamental technology, which is now a battlefield for companies and countries to have control of that. Because without that, there's nothing much you can do. And then it's going to be like the iPhone, right? Remember, the iPhone came in, it was a revolution in communication, but around the iPhone was built a series of applications. The same thing is going to be true here. You're going to have the core, which will be invested in by countries and large companies, giving you access like ChatGPT or Perplexity or all of the AIs applications that you see, but there are large language models. And there are going to be advanced large language models, which only a few companies and a few countries can manage because they're very complex with billions up to trillions of data points, not just data points, what we call nodes. So think of it as a system that will be at the core of almost all human interactions, not just in medicine, but beyond medicine. Then around that, you'll see a flurry of applications coming up for maybe a specialty of medicine, taking care of the, renal patients or whatever happens. I have no idea exactly what will succeed, what will not, but clearly there will be a ton of applications there, even open source applications that will be built upon that system. And then beyond that application system will be populations of particular types that require a particular type of healthcare and management and piloting of their healthcare, navigating their healthcare, things that will enhance your ability to provide what you provide, and that is, treat, cure, and manage the suffering of the patient population. And that's why, I said the most important thing here is to make sure that politics does not get into disease management, and it does. That's why the title of my book was Disease Knows No Politics. That's when you start having a shift where, top down, people say, oh, you do this, don't treat this patient, don't treat that patient, but treat this one. And those things are characteristic of our healthcare system today, where there is a top-down management and selection through pre-authorization, through denials, through political choices that are, in my view, counter to our oath as physicians, which is first do no harm to no one and make sure that you treat every patient who needs your help. So having said that, let me talk about healthcare for a second, and then we'll have Q&As. So I told you at the beginning, I think our science system, science and technology is second to none. I think the current policies of the administration might actually lower our ability to compete worldwide. I'm outspoken about saying that some of the things that have been decided, cutting the NIH budget, and not having an antagonistic relationship with universities and research universities, and all of that is basically a negative for the maintaining of our competitiveness and the ability of our scientists to do what they need to do. So having said that, we're working on making sure it doesn't damage the next generation of scientists. I think there are hopeful signs that Congress is actually not in unison with that. They just passed the funding bill, which maintains the NIH budget to its current level. So that's good news. But at the end of the day, when you look at the healthcare system, as I said, it was the best in 1975. It remained the best. But the healthcare system did not. It was the best in my view, and then it evolved to become not the best. And the question is why? So I'll share with you my view based on my experience, both in academia, in government, in industry, but also across the world. And if you look at the performance of healthcare systems in Germany and in France or UK or Canada, they clearly satisfy the population a lot better than they do here. I mean, the impact of costs on patients, the co-pays, the fact that premiums rise every year, become very, very hard to afford. But let me say what I think is the fundamental issue. And the issue to me is that there is an intrinsic fundamental misalignment within the healthcare system. And let me tell you why. Because the system is designed for providers to provide as much services as possible. Because of the RVU system and the fee-for-service system, you're driven to maximize the number of services you provide and multiply that so that at the end of the day, you have a revenue stream that covers your expenses and covers your salaries and so on. So that's one driver. But the other driver is the payers. And the payers, I recount in my book how they became involved in decision-making because their drive is to lower utilization. Because if they don't lower utilization, the premiums will have to increase. And what they do is they have created multiple ways of controlling, reducing the ability of providers to provide their services as they see fit, because there is a contradiction, if you will, between the goals of the two systems. Payers want to do less, providers want to do more. And I think that misalignment is crucial to understand. And at the end of the day, when you look at the $4 trillion that we spend, you realize that a big part of that is to control that tension. So when I was the executive vice dean at Hopkins, I spent 15% of my budget on fighting insurance companies, and they spent 15% of their budget on fighting me. So it was like an arms race between the documentation we needed versus what they required. 3,000 different insurance systems were in place. So I had to build an enormously complicated system to just fight off that tension between reducing utilization and augmenting utilization. We say it's for the benefit of patients. They said no, and I need you to pre-authorize that. So the story that I tell in my book is my own story. When I invented a test that differentiated benign from malignant lung nodules with CAT scanning, and I try to develop that test, and I try to make it as an invention, and I try to make it happen because it reduced the amount of surgery to be done at the time. And I'm talking about the 80s here. And the major companies refused to develop that technology. And I asked them why, and they said, look, our main clients are the surgeons, and you're not going to develop a test that reduces their ability to do surgery. That's not going to be very popular, and we don't want to do that because they are our main clients. So fast forward, I had to do a multicentric study with the invention I made, which was made at EVMS. And then what happened was, as I did the study over a period of 5 years, things started to change because thoracotomies were very expensive. You still had a 2-3% mortality rate. And as the study came out, showing the value of the work I had done in reducing and selecting the patients that should or shouldn't go to surgery, the insurance company said, okay, from now on, you need to do the Zerhouni test before you can be authorized to do thoracotomy. That was a shock to me because that was the first time in my career where I saw a payer essentially make a medical decision. You know, it was in my favor at the time because right after that, people said, oh, well, we need your invention now. And so the small startup that I created in Norfolk is still alive today because it controls the quality of all imaging, all computerized imaging. That was my idea at the time, and it grew. I'm no longer involved with it, but it's done very well. Why? Because it went with that trend of controlling quality and utilization, and it was used by insurance companies to control the level of utilization. So that tension is fundamental to our system, and it's really the issue that creates excess costs, 15% administrative costs that shouldn't be there. Now, you say 15%, well, what is it? What's 15%? Well, 15% of $4 trillion, $600 billion. You know, it's as big as the Medicare budget, a little less, but you see, and that doesn't create real there's no added value there. And then you have pharmacy benefit managers that come in the middle, that they have a business model that essentially extracts it's like middlemen, they're extracting a value. How? When I was in industry, if you had a drug that costs $100 in the US, the manufacturer, the creator of the drug, got $45, and the intermediaries, the middleman, will get $55. Whereas in Europe, with the systems that they had, and I'm not saying that their system is the best for us, but it's different. If you had a $100 drug, you collected $90, which meant by definition that the companies had to double the price in the US to make the same amount of revenue. Why? Because we have so many intermediaries. And in my view, about a third to 40% of the healthcare dollar is going to entities that don't provide a lot of value. All right, so that's one aspect. Now you understand that tension between payers and provider systems, and the fact that the system is designed to create a tension that needs to be managed constantly. How is it managed? That's the second problem. We have centralized all healthcare decisions in Washington, and we have a one-size-fits-all approach to the management of our healthcare system as one major big entity, which is 20% of the GDP of the country, all right? So you can understand the interests of politicians and vested interests and everybody. And then the question you have is that appropriate for us, really? And if you travel the country, which I did, you'll find that epidemiology in Mississippi is completely different than Minnesota or Colorado for various reasons, but clearly allocating the dollar the same way across all those regions, whether it be Medicaid, Medicare, private insurance, doesn't make sense. It's so centralized that it's worse than the Soviet Union. You know, we are doing it with, in my experience, when I was in Washington, about 100 people who decide everything in Washington for us. And I think this is an issue because it does not allow adaptability and innovation in what I call implementation research. So let me give you an example. I was at Hopkins, and I was working on CT scanning, and we developed a technique where we could actually scan the whole body in less than a minute and a half. And at the time, I said, well, this is really a revolution because you could see that imaging provided help in 65% of the cases. But the problem was it was all fragmented. you know, the ICD-9 code, the ICD-9, ICD-10, CPT codes made it that if you wanted a CT of the head, you had to justify it. And then if you want to extend to the neck, you had to justify that. And the thorax, you had to justify that. So the body was cut up to serve, you know, control of the utilization. And I said, that's ridiculous. I mean, we should really scan the patient the day they come, and then if you needed information, you just called in, you had the data, and you could say, oh, could you check the chest, please? The patient is coughing or has abdominal pain. Can you check? And with one price. I mean, that was it, because it was much less expensive to do it that way. You didn't have the transportation, the prescription, and you got the whole data. And what we proved is that the data does not get obsolete. And in the majority of patients, the data you get on day one is the same as you get on the day patients leave. So doesn't that look to you like a great, you know, potential innovation to be tested, to be, well, the general counsel actually told me, look, if you do this, it's a fraud and abuse case, because the system is designed to prevent that, to prevent overutilization. And if you do the whole scan, it's an overutilization. I say, yeah, but we can reduce the cost. And he said, well, but there's no CPT code for that. So today, you cannot do a pan scan of a patient, which you can do in 45 seconds and get a lot of information and get it covered by insurance. You have to pay it on your own. So you can see how the imbrication of the systems prevent innovation. So when you look at that and you see what happened over the past 50 years, you've had a huge rise of monopolies. There are now 3 major insurance companies in the country. And everywhere you go, there are healthcare systems that have merged and become monopolistic. Centara in your area controls 80% of the care. If you go to Pittsburgh, the UPMC controls 95% of it. So I'm just trying to enlarge your perspective and share with you my point of view. So what are the new medical models that we should consider? The first one, I think, is the regionalization of healthcare. That today it's so over-centralized that you can't adapt to your own population at the local, regional level. Every country I know has a regionalized healthcare system. I'm not talking about a national government-run system. That is the last thing I would advocate, having seen up close how government works. That's not the solution. What the solution is it's not a revolution, but a devolution. Give healthcare back to the people. Because right now, there's no patient at the table. In Washington, everything is decided, in my experience, by special interests on providers or on payers, politicians, and patients are not there. Patients basically are the victims of the system. 50% of all bankruptcies and financial hardship actually come from healthcare issues. So having said that, I think we need to find a way to depoliticize the system, to regionalize it to regions that are manageable, just like other countries do. Usually what we say today, anyway, is that 30 million people is about the size of a good healthcare system, a health system, but because you have enough diversity to not accumulate insurance risk. And the idea there is that if you could do that, if you could separate, then you will adapt better to your own local conditions to treat patients, especially when it comes to the distribution of chronic disease versus acute diseases and that important application of healthcare to both prevention as well as treatment. Then the other models that I think has future is to try to reduce that conflict between payers and providers, and that is the experience that you see in certain systems like the Kaiser system, where there is a combination of the two functions and the optimization of that with the results you know. But if you look at the surveys that the Kaiser Family Foundation does, every time you have an integrated system, you have better patient satisfaction. So my idea is to say, first, let's find a way to lower the politics. Let's find a way to devolve healthcare to regions Let's find a way to promote innovation and what I call implementation innovation. And clearly, at the end of the day, disintermediate the system, remove all the middlemen that do not add value, the steps that do not add value. I mean, having 15% of healthcare costs fought into administrative morass of denials and pre-authorization and all the steps that that is taking money away from the care of people. So I wanted to give you then this view. I want to give you a personal view of what I see as the profile of the physician of the future, the balanced T. I wanted to tell you that the complexity requires a team effort, which means convergence between physical sciences, social sciences, medical sciences, data sciences. You need to be familiar with the impact of that. I talked to you about probably the best, the best or the worst, I don't know, force or wave of technology, AI, which will revolutionize everything we know about healthcare to an extent. I don't know what extent, but it will make a difference. And then told you about what I see as the fundamental, what I call the rocks of why our healthcare system is not performing as well as it should, despite the fact that we spend more money than anybody else on it. So I'll stop here and I'll ask you to ask me questions, and I hope you enjoyed the conversation here. Thank you. I don't know how you want to organize the Q&A over there.
Thank you very much. That was a great talk. So, please feel free to ask questions. You have these silver boxes in front of you with a red circle. If you press and hold it while speaking, that will let everyone to hear you. Those who are joining us virtually, you can put your questions in chat, and we will ask those questions. Please go ahead, Dr. Arovich.
Thank you so much for raising the flag for EVMS. Thank you for doing that. Also, I wanted to thank you for talking about our healthcare system. I don't think in medical education we do enough discussions related to the system or the lack thereof. So I wanted to come on to your T as related to two specific proposals. Regionalization. Does that have anything to do with the best practice in the Department of Veterans Affairs, Veterans Integrated Service Network model? Is there something to be learned from the vision approach to you here? And then I have a follow-up.
Well, I think the VA is an example of integration of the payer and the provider, right? I mean, if you really think about it, that's what it is. It's an integrated system where the tensions are managed, but they're managed on a regional basis. They're not managed as a one-size. There is a one-size framework, but it's really adapted to the different regions because it turns out veterans are not distributed equally either. So no, I agree with you. I hadn't thought about the VA. I was thinking more about integrated, like the Kaiser system and the value-based care concept. Now, you probably heard about value-based care, which is to put providers and insurers on the same side of the table. It doesn't always work because of the rules and regulations that are underneath of it. Make it the degrees of freedom in you adapting to the population you're treating very, very low. Just like I said, when I wanted to I had invented it and apply a very fast imaging process workflow where you would, do one test and have 95% of the information you needed in one test that would be basically reducing. Well, it violated the rules and the regulation that says for each test, for each part of the body, you have to have a prescription. That's designed to control utilization. It's not designed to help the patient, So that's the kind of thing that a VA can do that others cannot do.
Okay, and then the follow-up, as far as your horizontal T portion is concerned, relates to population health, epidemiology. You use those terms several times.
Yeah.
Are we doing enough? Are we doing enough in training our learners on population health and epidemiology?
I don't think we do. I mean, that's the message really, is adapt to your own locality. There is data though. I mean, if you go on the CDC website, I hope it's up because of the shutdown, I don't know, but I always went there. And I'll show you these slides that you can see updated all the time. And you say, what's the map of obesity in the country? Right? If you just draw it and say, okay, what's the map? And you see, look at it, it's not distributed equally. It is so amazingly Southeast US is like twice as much. And then you have Southwest and the Indian population, the Mexican population, very different, than the rest of the country. You go to Colorado, the obesity rate is the lowest in the country. It's comparable to your European country. Why? I don't know if they just hike a lot or whatever, but it is what it is. And adaptation is therefore should be part of the process, but we're prevented from doing that because there's a one size fits all, one size regulation. Now, having said that, look at the issue that we face in terms of improving healthcare. Now, let me tell you, when I was the NIH director, we had this plan of providing drug coverage for seniors. Seniors at the time were essentially forced to choose between food or drugs, and it was, heartbreaking. And so the president said, we need to cover these patients. Now, you would have thought that this would be a slam dunk. I mean, covering older Americans who can't afford their drugs. I mean, who can be against that, right? And yet there was a huge battle, political battle, where the thing passed by one vote only. I mean, to tell you how divided the things are. So you fast forward and you look at Obamacare. When he proposed that, what was the goal? The goal was to provide insurance to 40 million people who didn't have it. And so they were thrown out of ERs, and you could see these scenes of complete despair for a large part of our population. For a rich country like ours, it was a slam dunk. Who would argue about protecting 40 million people, especially children at the time? Shouldn't be anybody. But again, if you remember, it was a huge battle, and it passed by one vote. And so when you see that, you realize that you can't really change the system from the inside, with that sort of process. You need to redesign the system from the outside and say, from now on, let the regions adapt to their own healthcare. But having said that, you need to have a base program, a base offering of healthcare services to the entire population, including the 20 or 30 million who are non-insured. That's what other countries do. So you have a basic service level. And then if you want to add insurance, on top of it, you can do it. It's like Medicare Advantage, So that's the concept that I think could work if you really made it happen in a regional context. Why? Look at the Federal Reserve. You think the Federal Reserve that decides healthcare, rates and so on, it's a decentralized organization. It has 12 economic regions because they realize that the economies of region X is not the same as region Y. And so they have 12 governors who then come and assemble all of the economic data in their area, and they drive the economy of their data to their banks and so on and so forth. And that system works. It's one of the best in the world in terms of adapting the economy to its needs. We don't have the same in healthcare, and yet we're 20% of the U.S. economy, growing. Next year with the shutdown, if they don't fix what is being asked to fix, which is the vouchers for insurance, the insurance costs for the people who rely on Obamacare is going to double. And that's where one party says it's great, then because they wanted to destroy Obamacare anyway. And then the other party says it's terrible because our constituencies are not going to get served. And so you end up with this completely irrational system, which is based on a series of rational decisions for each component of it. Now, if you as a physician, does not open up to that complexity of the system, you'll be basically the vertical T, bar, but you won't understand the connectivity to your particular impact on society.
Thank you. There's a question online, Dr. Ascona. He asks, you describe misalignment between motivations of payers and providers. What about substitution of business ethics for medical ethics, that is greed, on the part of one or the other? Is it really benign fiscal malalignment, or is it opportunism to make money from an essentially captive customer that is a suffering patient?
Well, all of the above. First of all, if you separate financial issues from policy, you are naive. I can tell you when I was in the government, sometimes I didn't understand why people would oppose something or be in favor of something. 90% of the time, you found the explanation in what I call revenue flows. In other words, you can understand why somebody is doing what they're doing if you can track the financial impact of what they're advocating for. You know, that is the nature of human nature. And I don't think you can separate the two. I don't think, you know, greed is when it becomes, you know, almost fraudulent, right? But for-profit is not something that our society bans. We don't ban for-profit, but excessive profit and maldistribution of the profit relative to the mission of what you need to do is a problem. So you look at nonprofit organizations, hospitals, hospital chains, and so on, look at the share of services they provide to their community, and you find out that they've been misdirected. I mean, they make billions of dollars in profit. They store the profit for rainy days. You can see the compensation levels, which are public, of CEOs of healthcare systems. I mean, they are paid more than if they were for-profit CEOs. So there's something wrong there, which you call greed, which I call, in my view, distortion, which needs to be repaired. Now, let me give you another example. The Congress often gives monopolies to special groups, special interest groups, right? For example, why is colonoscopy, you know, we're talking about drugs that are three times more expensive here than elsewhere. But why is colonoscopy 10 times more expensive than elsewhere? Why is an ICU day 10 times more expensive? Why is an MRI 10 times more expensive than you could do it in France? When I was there, it was $300. Here's 3,000 or 1,500. I don't know. There are these distortions that are related to the questions you're asking, that Dr. Ascona is asking. And that means we need to we need to have transparency in healthcare. We don't have it. You don't even know what it's going to cost you to have a knee replacement or a hip replacement. You just basically sign on the authorization and the consent form and wish for the best. Well, that tells you that you have motivations that are related to underlying what you call greed, but what I call self-interest, which needs to be corrected. So the colonoscopy thing is very simple. I mean, the reason is the Congress gave monopoly to the gastroenterologists. I hope there's no gastroenterologists here that will resent this, but it's true. It was done for a good reason. It was done for a good reason at the time, which was that the endoscope were large and rigid and not very flexible. So you had a lot of perforations. And because of that, people went and argued that it couldn't be done by anybody. It had to be done by a trained gastroenterologist in a facility where surgery was available. That was 30 years ago. And today, you know, you have these flexible endoscopes. You can do it in an outpatient facility and so on, but the rule has not changed. And so there's a mini monopoly that's been created, which when you have a mini monopoly, you basically can increase prices to your liking.
So I will then next give mic to our gastroenterologist, Dr. Waldholz, to ask the next question.
Well, first of all, thank you, Dr. Zerhouni, and thank you again for being here. I didn't have a question as a gastroenterologist, but just as a point of reference for our students and residents, Kaiser Permanente, using a system of fit testing, not a point of service like a local system did here, eliminated healthcare disparities at a much lower cost. Took them about 8 years. But my question is for our individual students and residents who are going to be going out there in the community, could you share with them the power of joining a patient group for advocacy up on Capitol Hill rather than joining, say, the ophthalmologist, the GI people, and the orthopedist and the dermatologist up there asking for more money for me. And along the same token, the American College of Surgeons decided to not sign on the bill that was in Congress within the doctor's caucus. They were going to go ahead and create a 5-year Medicare patch, and they said it wasn't enough. The doctor's caucus threw up their hand and says, "The heck with it. We're not going to even support this," to the Republican caucus. So
I'm glad you asked that question. It's really an important question. Just so you go about the gastroenterologist, I don't mean that they should not be at the center of the provision of services, but they should do it in a different way. So if you go to Japan, I was just in Japan last week, and I had a visit to the Haneda Hospital. Haneda is the main airport in Tokyo. And you can fly in from any country, get a total physical plus colonoscopy and so on for about $1,500, with the testing and everything. It's a big market there for high quality healthcare. The reason it works is because the one gastroenterologist supervises 20 labs run by trained nurses, and then he looks at the screens and then intervenes when there is a polypectomy or something like that to be done. So it's the implementation strategy that changed in these countries, which hasn't changed here because of the regulation. That one is one point. But to go back to your point, you cannot be more right than what you just said. We are not connected enough to the patient groups. And now let me tell you my experience, all right? When I was at the NIH, we had 478 patient groups. And obviously you have the scientific groups, the universities, and so on. Every time I went to Congress, you know who the best advocates were for NIH? The patients. And who was listened to by the legislators? The patients. Today, it's even worse. Today, they don't even want to hear about the elite and the experts. And now we're in an expertise-free zone. Anybody can say anything they want, like vaccines are bad and so on. There's no check. The only check are the patients. And if you really look at that, for example, for the NIH budget, I can tell you the reason it didn't go down is because the patient groups who want cures for their family and for their went to Congress and went to the districts and talked to the legislators, talked to the administration, and the administration realized, wait a minute, there is distrust of scientists and elites and universities and so on, but there's no distrust of patients' needs. And if you talk to the patients' higher trust is doctors, nurses, So yeah, maybe there's distrust of vaccine by some, but when you survey and you look at what the people think, their doctor is a source of trust and their nurse is a source of trust. That is something that we have, which we're not using enough. And I completely agree with you. That should be a strategy saying, hey guys, providers and patients should be on the same camp here, not fighting each other.
Thank you. Other questions? So I have one question. We have quite a few medical students and residents and fellows in the audience, and I'm sure that some of them at least are thinking about careers in research and biomedical sciences. And any advice from your illustrious career that you can give them, direct them how they should structure their development from here?
My first advice is to consider that, because the science career is going to be even more interesting than before. There's always this sort of catastrophe, the sky is falling. But let me tell you, there is a huge retirement wave from the baby boomers. Starting in 2021, there's been an increasing retirement. And then when you look at the funding, that is not going to go down. Now, it might be important to decide what kind of research you want to do. Basic research is very needed. That's the area where America excels. You look at all the Nobel Prizes that have been given, and you can see 2/3 of them are American Nobel Prizes, even this year. So that is something that will not go away. Second, it's very hard to really have a career without understanding medicine, and especially in translational medicine. So there are multiple pathways to a scientific careers, from basic to translational to applied to what I call healthcare research, healthcare system research. And so I would be encouraging that, because I'm not so sure that life as a practicing physician would be sufficient to sustain a career. I mean, you have to have that done, because, as I said, you're going to be part of a team, part of it's a team sport, and that can be satisfactory or not. If you're more into the creative side of healthcare, you want to do something new, then obviously a scientific career or scientific related career is more interesting. But I don't think the advice to me is to look at the options. I mean, there are many options right now. I see more doctors in industry today than I did before. I see more doctors in NIH-funded centers. The problem is physician scientists, when you have the obligation of maintaining a clinical service and doing research, that's very hard. That's very hard. So I think that you need to decide whether you want to be on the science side or the physician side. Decide what the emphasis should be. Don't think you can be both. That's my advice, is that I've done it. It means 14-hour days, and it's not something I would recommend. I have a daughter who's a surgeon, and I said, you can only excel in one thing at a time. Don't try to do multitasking because science is competitive, medicine is competitive. So if you want to excel, the vertical T, if you're a physician scientist, it's like having a double vertical, right? Well, you can't be good at both to the same extent using the same amount of time. So be selective is what I'm saying. Just find out who you are and then follow that, but 100% effort. If you do science, stick to science. Your medical background will be so valuable anyway. But it should be a 90-10 activity, not a 50-50 activity. I don't know if that makes sense, but that's my advice.
Thank you. Thank you for that valuable advice. There are more questions, but we are running out of time. We thank you very much for your time, Dr. Zerhouni. We learned a lot. Thank you all for joining us. Have a wonderful rest of the day.